بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على نبينا محمد. Today the lecture is so long, so what really my aim is for pattern recognition, then touch on a very important point. We cannot go really in details because talking about eyelid lesion, benign and malignant, and you go for treatment options, especially with the really very interesting treatment options are coming to the horizon, is really going to take a long time. So just I'm going to give you the basic, then at the end I'm going to touch on very important topic that most of you know about, but I'm going to stress more on it. Before we go, we need to know about the layer of skin, because most of the tumor we are going to handle or talk about are happening in this part of the body. We have the epidermis, which formed by 5 layers, then followed that by the dermis. Then after that we have subcutaneous fat, as you can see here. Along with that we have skin appendages, which mainly the sweat gland, oil gland, and the hair follicles. As you know, the most important tumors that we deal with, they come from the epidermis or adnexia. Main goal of this one is to recognize malignant and non-malignant process, because that's really the thing that you don't need, you should not miss. How we know this malignant or non-malignant? By identifying the characteristics of malignancy. And whenever you are suspicious, anytime, biopsy will save you. So biopsy takes few minutes, but will change the whole management. As you know, most of the tumor we deal with in the periocular area is mainly basal cell carcinoma, which is the most common, followed by squamous cell carcinoma, and also we have sebaceous cell and melanoma. What are the characteristics of malignancy that you really need to be familiar with? Is ulceration, which is the most typical one. Ulceration doesn't happen in benign condition, it happens mainly in malignant condition. Induration, and this is also a very often or common sign in malignancy. Irregularity, malignant lesions tend to have irregular shapes and borders, and change in the normal architecture of the eyelids, meaning you will see destruction of the eyelid margin, loss of eyelashes, or invading punctum, for example, and canaliculus. Tenderness, malignant lesions typically are not tender. So if you see a tender lesion or a painful lesion, you need to think about something else. Telangiectasia, also very suggestive of malignancy. And billy borders is really very common feature of basal cell carcinoma. As you know, most common eyelid malignancy is basal cell carcinoma, reaching around 90%. That's true for Caucasian, but here is variable, and we don't have really an accurate registry for how common basal cell compared to squamous cell and also sebaceous cell. But still, even in our community, especially with the registry they have here in KKH, basal cell is still the common, but it's not by this percentage. It's common in fair skin type, as you know, and it's common in the medial canthal area and the lower eyelid. And as you know, the billy borders with telangiectasia is one of the common feature in this kind of tumor. And this is a typical example. You can see the ulceration, you can see the telangiectasia, and you can see the destruction for the architecture of the eyelid, loss of lashes, and you can see the billy borders. So all the sign, you see it in this clinical photo. So again, just to stress in the importance of characteristic of malignant lesion: ulceration, induration, irregularity, destruction, non-tenderness, telangiectasia, and billy borders. This is another patient showing the same feature we talked about. You can see the ulceration, induration, telangiectasia, billy borders, and destruction of this area. And I hope the patient can speak to tell you that it's not tender. And this is another picture to show you the same features again. What we see in our area a little bit different, because our skin type is more pigmented. All what I have seen people from our area, they come with pigmentation. If you see people from Syria and other white skin, they usually present like what Caucasian feature have, but our skin type tend to have more pigmentation. So if you see a pigmentation and with other typical feature of basal cell carcinoma like ulceration, induration, billy borders, destruction, this is basal cell carcinoma until proven otherwise. Is my voice clear for everybody? People at the back, you're okay? Good, thank you. Squamous cell carcinoma also very present in a similar fashion to basal cell carcinoma with other features we mentioned like ulceration, induration, and others. It occurs mainly with the skin damage area and sometimes preceded by actinic keratosis. It typically tend to occur in more elderly patients and male in particular. The other tricky part of squamous cell carcinoma, it can be seen in a scar, burns, and area of previous radiation or trauma. So sometimes you think, oh, this is damaged skin from other reason, while it can harbor squamous cell carcinoma. So you need to be really very suspicious. And as you know that squamous cell carcinoma is more aggressive and also tend to spread along the nerves. Basal cell carcinoma is mainly locally destructive, but it doesn't usually spread through the nerves like squamous cell carcinoma. And this is one of the patients with the squamous cell carcinoma, and you can see the ulceration, destruction, and you can see the extensive skin damage. You can see the sun damage in this patient, telangiectasia, thinning of the skin, and shining. What's tricky about squamous cell that sometimes you think it's a small, but when you go and you do more surgery, the defects become way more than you think. So it has like a spread beyond what we can see clinically in our naked eyes. Basal cell carcinoma is not like this. Usually it's around what you expect. But for both of them, you need to do clear margin. Sebaceous cell carcinoma is another malignant that, alhamdulillah, is less frequent. Different in the presentation, like different from the other basal cell or squamous cell. Usually it's not telangiectatic, ulceration, irregular, barely border like what we mentioned for squamous and basal cell. But they have another, let's say, a special feature for it, which is vegetoid spread, late ulceration, but not early ulceration, and multifocal origin, which makes it very difficult and challenging to manage. Other thing about sebaceous cell, that it can come with another lesion that we think it's benign, like chalazion, unilateral blepharitis, conjunctivitis. So we need to be really suspicious about sebaceous cell in these kind of setting, especially when among elderly patients. So you can see the conjunctivitis here, but you can see the loss of lashes, which is sign of malignancy. So in this setting, you need to think about it. And you can see the thickening of the lid, which is really not typical for blepharitis. So when you see something like this, you need to biopsy, especially if it's unilateral. And you can see here the late ulceration because of a squamous cell, sebaceous cell. And you can see here some swelling too. And this is another patient presented with the chalazion-like picture. And it's really a good habit when you see a chalazion-like picture to invert the lid and see what's behind. And this patient, we found that telangiectatic and also some what looked like a hemorrhage under the conjunctiva. When biopsy, it came to be sebaceous cell. So these are like things that may simulate sebaceous cell. So make sure that it's a sebaceous cell, not something else. If you are in doubt, anytime you go for biopsy. Sebaceous cell, as you know, it may originate in meibomian gland, which is the most common organ, but can happen with other sebaceous gland in the eyelid or in the brow. You can shave biopsy may show only inflammation, do wedge resection, or fat stain for fat. So you need to take really a deep biopsy to get this tumor diagnosed. So it's not enough to take just the superficial part, because it could be just inflammatory component. As you know that sebaceous cell tend to metastasize through the lymphatics, so we need to make sure that there is no lymph node enlargement. And even some people, they go, even if you don't clinically observe lymph node in the pericular area, they go and biopsy it. This is patient with localized sebaceous cell. And as you know, when you do biopsy and you confirm diagnosis, you need to do what you call map biopsy, because you know the sebaceous cell has a multifocal origin, so you need to biopsy the conjunctiva, either palpebral or bulbar, from different areas, and there is different techniques for it. And if you're interested, you can. It's really illustrated nicely in the literature. See this patient with positive lymph nodes here. Most what I'm presenting is from, you can find it in Dr. Nirad book, because he trained me, so I took most of the picture from him. Sometimes you get something that's simulating sebaceous cell, so then you need to do a biopsy. And luckily for this patient came to be sebaceous cell adenoma. And these adenoma, you need to also send the patient for a GI doctor, because they may have intestinal polyps and adenoma. Okay, we'll move now to pigmented lesions, mainly that we're talking about the benign. The benign lesion usually tend to have uniform color, symmetric shape, and regular border, like this one. And as you know, not all pigmented lesions are nephi. As we showed before, basal cell carcinoma and pigmented skin or dark skin like us can be pigmented. Not all nephi are pigmented, and as you know, that's especially in elderly, it can be endodermal, so it's not pigmented. Any lesion may be pigmented, so you need to be wide open to differential diagnosis with pigmented lesions. The most important pigmented lesion they need to be aware of is melanoma, because that can kill the patient. So early diagnosis and proper treatment may save the patient's life. What are the features? The recent onset or change in color, shape, or size of any pigmented lesion. You need to raise a suspicion of melanoma. If you see different colors, density, they need to raise suspicious for melanoma. Irregular border or notching, asymmetrical shape. If it's a large size, also you need to suspect melanoma. If there is ulceration or bleeding. And as a rule, whenever you are suspicious about a lesion, do a biopsy. We're not going to harm the patient. You can see here the different in colors, irregular borders. This should be suspected for melanoma. And also these lesions should be suspected for melanoma. And this one, you see the size is big, so also is another indicator for suspicion of melanoma. There is other tumors, but they are not malignant, but can be pre-malignant, and which are the actinic damage. And actinic keratosis is a very malignant condition from skin damage. Keratocanthoma also another thing that you need to be aware, because it may change to malignancy in the future. There's other epithelial tumor which are raising mainly from epidermis, and also some of them from the adnexia. Actinic damage is, as you know, is a result from exposure to ultraviolet light, and also can be part of aging process. The sun damage usually cause mottled pigmentation, epidermal atrophy, so you can see the skin very shiny and thin. You can see deep furrows and wrinkles, rough scaly lips. These are signs of damage, plus telangiectasia. And you can see these features. You can see the telangiectasia, the skin is rough, and in some patients, this patient is rough skin, but some of them, they can have shiny, thin skin, atrophied skin. Actinic keratosis, usually it appears as awful erythematous papules or bacules with rough, adherent white scales associated with actinic skin damage. So you don't see it in a patient that doesn't have actinic or a sun exposure sign like telangiectasia and atrophied skin. It can be multiple lesions in the face and also in the back if a patient have sun exposing in the back. Early lesion may feel gritty because of the scales on it. It can convert or can be squamous cell carcinoma down the road. And the treatment for it is cryotherapy, plus some people can use 5-FU and other modalities. And you can see this lesion. You see the scales and white scales, and you can see the skin damage, but not clear in this picture because it's focused. Keratocanthoma is another benign tumor that may lead to squamous cell down the road. How it present? Usually present with rapid growing dome-shaped tumor with central keratin-filled craters. Rapid growth usually happens in a few weeks. Then after that, involution takes a longer period, sometimes reaching up to 6 months. As you know, it may lead to squamous cell. And biopsy, really important for ruling out the malignant component. And this is a typical feature of keratocanthoma. And this is after excision. Another form of benign lesion, acrocordon. It's a form of it's a really fibroepithelioma. Typically it's pedunculated with a flesh-colored tumor, common in the eyelid, but also can be seen in the neck, axilla, and groin, and usually it's multiple and small one. And this is a typical picture for it. Seborrheic keratosis is another common benign lesion that we see. It's usually in the earlier stage is a small one, but sometimes can get bigger and thicker with time. And the nice thing about seborrheic keratosis is that it's easy to recognize because of the button and multiple places that you can see it. You can see it in the eyelid, you can see it in the back, especially in elderly people. The color can be light and can be dark, depending on the skin type and depending on the seborrheic keratosis. Seborrheic keratosis is usually multiple, extremely common, and benign, which it's a form of benign proliferation of normal epithelial cells, and shape biopsy or excision whenever is needed. And this is a typical appearance. What they call it stuck-on appearance. So it's like a keratin stuck in the skin. So when you do shape biopsy, it just peel off nicely. We'll show you example for it in a minute. Cutaneous horn is more of description, not a diagnosis, because it can happen with multiple causes. Can be seen in seborrheic keratosis, can be seen in verruca vulgaris, can be seen in Nevus, actinic keratosis. It can be seen also squamous cell carcinoma and basal cell carcinoma. This patient with seborrheic keratosis with cutaneous horn, and this is after shaving. You can see you just shave it off and the skin will heal up nicely. And this is a patient picture after procedure. Squamous papilloma is it's a pedunculated flesh-colored tumor. It's also another descriptive term. It's not a diagnosis because it can be seen with other skin tumors that we just mentioned. And this is from viral infection. It's squamous papilloma. Epidermal cyst, or people call it inclusion cyst, is another common benign lesion we see. It presents with whitish dermal or subcutaneous round cyst. It contains cheesy desquamated keratin, not a sebaceous cell. So people call it sebaceous cell, while the true name is epidermal cyst. I'm going to show you a picture for it. It may become infected or ruptured. Open with the blade and you can just remove the content. Like this one. This is not sebaceous cyst. This is epidermal cyst. This is another picture for it. Amelia, another common condition that we see that present like a rice kernels, they call it, common among newborns, and you can open it with a needle or blades, but it's really take time because it's really multiple. So if you are free in the clinic, you can go behind them. Otherwise, just leave it alone. Pigmented cells, as you know that the melanocyte found in the basal cell layer, and amount of pigmentation depends on age and also on the race. You see this is the epidermis and this is the dermis, and the melanocyte in the basal layer of the epidermis. Melanocyte nephi, pigmented or can be pigmented or non-pigmented, can be small or large, elevated or flat, depends on really on the age. And it comes in three, or we call it three types. Can be junctional, compound, or intradermal. Junctional mainly in young age, as you know that the melanocyte are present in the junction between dermis and epidermis, so in the earlier stages it's junctional. Then after that become compound and become elevated, and this happens typically in the second year of life. Intradermal, and this is becoming, especially with age, to dip inside the dermis. So with this, the nephi loses its pigmentation, so it becomes non-pigmented, and this happened usually later in life, around the age of 60s or 70s. Just to show you interesting the life cycle of the nevus. This is junctional, this is compound, and this is intradermal. And this is another intradermal. Congenital nephi that can be seen since birth and can be large or small, variable from one patient to another. Like this patient, and also this, what you call it, kissing nephi. This is for the epidermis, but we have adnexial tumors or lesions that can arise from the hair, oil glands, and sweat glands. And from the hair, we can have a benign condition, or actually more of an inflammatory or infectious process like external hodiorum, which mainly around the anterior lamella, anterior hodiorum, which mainly around the meibomian glands, chalazion, and sebaceous hyperplasia. So this is a typical chalazion picture. Sebaceous hyperplasia is a form of a small, shiny, yellowish papules with the central umbilicated appearance. It's seen in the forehead and also in the cheek, common in patients over age of 40. And this may mimic basal cell carcinoma. That's why we discuss it here. And you can see it here. This is the brow, and this is a buffalo-brow. You can see the central application and yellowish shining lesion. So this is not a basal cell carcinoma. This is not ulceration. One of the adnexial tumors is sweat gland origin tumors. Can be exocrine or apocrine. Exocrine like syringoma and ecrine hydrocystoma, and apocrine can be apocrine hydrocystoma. Syringoma is a bilateral small multiple papules, common in the lower eyelid, especially in women, and it appears like flesh-colored or yellow lesions. It's raised because the origin or the syringoma happens because of benign adenoma of the exocrine sweat ducts, most common adnexial tumor that we see. The problem is because of its small and multiple, like you see it here, it's very difficult to treat because it's difficult to go and excise it surgically. Other people tried CO2 laser. It helps in it, but in our skin type, we need to be careful about the pigmentation. Apocrine hydrocystoma is a solitary smooth cyst near the lid margin. This is apocrine near the lid margin. Common in elderly or middle age, and this is a typical appearance for it. This is another one nearby the punctum. We have also different type of benign tumors from the hair follicles. We have the tracheoepithelioma, tracheolimoma, and tracheofolliculoma, and bilimetrixoma. This is what I've been seeing more frequent than these. I haven't seen any of these, but I've seen like 5 patients with bilimetrixoma. Other people call it calcifying epithelia of Malherbe. And this is one of patients. You can see it around the eyelashes, like in this patient. Also, you can see it around the eyebrow. So whenever you see lesion in that area that looks like chalazion or sebaceous, you need to, like chalazion or epidermal cyst, you need to suspect this tumor. This is after excision. Whenever you have suspicious lesion, you need to biopsy, and biopsy can be different modality. And it can be either shape biopsy, incisional biopsy, or excisional biopsy and closure. Shape biopsy best for papilloma, seborrheic keratosis, or nephi. Like this patient, you just shape it. That's it. You just let it heal by itself, and the skin will grow without the need for closure. And also for this this papilloma. And this is after excision. And this is for seborrheic keratosis. This is after chafing, and you don't need to close. You just chafe it, and it will heal up nicely. Also, you can use it for fungated lesion like this one. You just chafe it, and with time the hair will grow back. And also good for lid margin lesions. For cysts, it's good to do marsupialization or excision and closure whenever you think it's needed. For this one, you just do marsupialization, and you just let it heal by itself. For this large cyst, you can just excise it if you manage. Otherwise, you can do marsupialization. Punch biopsy, it's really good for tumors like this, so you can take a border of it so you know what is it. Then you can do more definitive treatment. Excisional biopsy is the goal whenever it's possible, but not possible for all patients. This is a patient with basal cell carcinoma. It was in the middle canthus. This is after Mohs surgery. After creating a defect, especially after a major tumor removal, you need to do reconstruction. And the basic principle when you do reconstruction for the eyelid is to respect the anterior lamella, posterior lamella, and also need to form the lid margin and respect the lateral canthal tendon and medial canthal tendon, because this is what can stabilize the eyelid. Lid reconstruction really depends on the size of the defect, and also it depends on which layer the defect is occupying. Eyelid reconstruction can be either direct closure, skin grafting, lacrimal reconstruction if you are dealing with the lacrimal drainage system, or you can use tissue flaps. This patient with the small defect here with just direct closure, it's very important when you close skin like this not to make the tension this way, make the tension this way, from lateral to medial, not from up and down, because if you make it from up and down, what's going to happen? Ectropion. Okay, so you need to make the tension this direction. Sometimes, like this patient, if you can do direct closure with the gray line or the lid margin reformation, that will be the best, like in this patient. Sometimes you need to do, especially in elderly, you can do it with a direct closure because they have a really lax eyelid. Skin graft is another option. If the posterior lamella is intact, you can do just a skin graft on top of it, like in this patient here with a defect, and this is after skin grafting. Skin graft takes time to match the other skin, so the patient needs to be aware that it's going to take time to heal up. And this patient with the posterior lamella was intact, so the skin graft was placed. This is another patient that has a lesion here, and she has skin removal, but you can see the posterior lamella is intact, so the skin graft was a good option. Skin graft heals really good in the fair skin, but in our skin type, maybe will not heal as good as this, so we need to be aware of this. Sometimes the defect is more than possible for direct closure. You go for canthotomy cantholysis, or you can do another surgical techniques that we're going to touch on. This patient with a large defect is between 25 to 50. So we can do canthotomy cantholysis. So you cut the canthotomy, then you do the cantholysis, so you will be able to approximate, as you can see in this picture. Sometimes the defect is so big, so you can do rotational flaps. So you relax the skin over here, so then you rotate the whole cheek here to reconstruct the area without the need for skin graft or other modality. As you know, the tissue flaps provide the blood supply with it, so you bring the tissue with its blood supply. That will decrease the chance for contracture. Also, it will decrease the chance for infection, and it will give a really better skin match or color match compared to the skin graft. If the defect is more than 50%, you can still do canthotomy cantholysis, especially in elderly patient, and also maybe utilize other modality like tensile flaps, Hughes flaps, and cutter beard procedure. This patient with a large defect, and this is a very good candidate for Hughes flap. So you get a tarsal conjunctival flap from the upper lid, and you attach it to the lower lid. And you have option, either you put a skin graft or you advance the skin from back to above, especially in elderly, so you have abundant skin. It's very important when you do anterior lamella and posterior labella is not to put graft over graft. You can put a graft over flap, but not graft over graft, because what happens if you put a graft over graft, what's going to happen? Necrosis, okay, so it should not be done. This patient with the larger defect, so Hughes flap was created, plus some rotation flaps from lateral to medial. And you can keep the flap from 3 to 6 weeks, so people are variable on this, and depends on how large the defect is. This is a glabellar flap. If you are dealing with a medial canthal area defect, you can just create a glabellar flap, then you rotate it. And this is just shown the picture here. If If the defect is so big, you can go for medium forehead blab. So you can take the blood supply with it and you just rotate it like in this picture. You need to be careful about infraorbital nerve when you go in this, or actually supraorbital nerve when you go in this direction, because the patient may end up with paresthesia. If it is very huge, you can extend all the way to the scalp. As you can see, this is graft, so you need to put on top of it flap. That's why we do the flap here, because all this is our graft. And this is what you call master cheek rotation. So you have a large defect, you can just release all the flaps from this direction and turn it toward the eye. And this is what happened in this patient. You can see the large defect. From here, the master flap was made, and this is a patient picture. Usually in the start, it looks ugly, but with time, it will heal up and relax. This is a patient with with a big defect, and this is after extensive master cheek rotation flap. What happens if you have the upper lid defect? So you can do the opposite. You can take the tarsus from the down to up. Other trick, especially if the upper, which I prefer and do, if you have a large eyelid defect, you can take a tarsal flap from the upper eyelid and the other side, if the other side is okay, and use it as a posterior lamella. But you need to have enough skin so you can rotate it, so you will have a flap over graft. This is a patient after cutter beard procedure. One of the things really I want to stop on here and talk a few minutes about it. You know, now the surgical procedure is the goal, especially if you can control it. But now with the really good number of medical treatment are coming at the horizon, especially with really good outcome, several medications have been tried for treatment of skin tumors, especially for that tumor that not in the threatened area, like medial canthal area, or that area that you have a better control. There is a good trial of 5-fluorouracil that showed a good effect, but now people are more toward drugs that manipulate the immune system, and the very good success have been achieved with the squamous carcinoma and the conjunctiva, and you know, with the interferon, conjunctiva tumor just milled out. So from there, more medication are coming. The one that really becoming very popular is imiquimod for basal cell carcinoma, or we call it Aldara. It's very good in basal cell carcinoma because what happened, it works in stimulating the immune system. It works, it's a receptor 7 stimulation. So by stimulating receptor or agonist for receptor 7, you will stimulate the interferon, interleukin 6, 1, 2, and 10, and that will help the immune system, either the innate or the acquired, to fight these tumors. And very, really impressive results have been accomplished with this treatment modality. So now more and more treatment now using this medication plus other medication in advanced tumor, like that it's beyond the excision, like if squamous cell carcinoma invading the orbit, you can try these medications. For a basal cell carcinoma, also we can use a photosynthesizing agent like methyl aminophenolate cream, and also acetylenic retinoid tazarindode, or retinoic acid they call it. These are very good treatment options, especially in areas that you can wait and observe the patient. But however, in the eyelid, if it's in an area that is really critical and you're scared about invading deeply, you can go for traditional surgical options. I don't have much experience with this medication because we don't see the tumor a lot in our area. But from the literature, there are a lot of publications. Even now, the Aldara, they're using it for melanoma, and with good response in a few case reports. Okay, thank you so much. Any question? Yeah, but usually you keep it for short duration, 3 to 6 weeks. So still you can do it, but it's not going to be the first choice. If you can go by with other option, I would rather do that one.
Other issue about the sebaceous gland carcinoma, it's commonly upper lid, but do you have any specific features, for example, lesion that can give me a hint that this could be sebaceous gland carcinoma?
Yeah, recurrent, plus if you invert the eyelid and you see some changes from inside, that tells you it's not a clinic. Yeah, it's not suspicious. And especially if when you open it and you don't see the typical appearance of the fatty content in the chalazion, it's good to send that for biopsy. Um, uh, to remove this or to have a hidden scar, usually what I tell people is depends on the gene. Whatever you give people, they have held up nicely. People, whatever you do, they have colloid formation tendency and others. So mainly depends on the gene. You can give many options, but really not medically no proof in one. However, if a patient you see that is going to go for fibrosis or creating, for example, lid retraction and other things, you can give steroid injection. You can inject 5-FU, which I use really frequently. That will, let's say, modulate the scarring, so will not have complication like lid retraction and other contracture from the surgical intervention. It depends on the location and accessibility for surgical treatment. So it really varies from one patient to another. If you surgically can be excised safely, why not? If it's in an area that is not critical, you can try medical treatment because it's really showing very effective results. So it depends case by case. Okay, thank you so much.
Yeah, this is the ground.
That's water for you. This point. Compound from this side. Only one thing. Change the slide.
Start keeping you.
Right to left.
Back to this time.
Yes.
Too much anything هنا بالماوس.
اي بالماوس ممكن تجربون دكتور. تمام دكتور.
السلام عليكم كل عام وانتم بخير. It's my great pleasure and honor to introduce the speaker of the grand round today, Dr. Munar al-Naggar. Dr. Munar al-Naggar, he is a very active member of the Retina Uveitis division at the Department of Ophthalmology. Today he will discuss a topic which is of major interest, which is herpetic anterior uveitis. So I am sure that this lecture will be very useful for all of us. Dr. Munar.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Prof, for this introduction. And when I choose this topic, really, I thought it's a very easy topic. But after I choose it, I found myself in a maze of a group of diseases that as easy as possible to treat and diagnose patient with herpetic keratitis, it's difficult to correctly diagnose in time patient with herpetic uveitis and manage, and also which leads to correct and proper management and avoid complication. So we know that the word herpes, it's coming from a Greek word herpein, which means to spread. It means that these type of diseases, it becomes collected in one place, and then later on it can spread and reactivate in response to certain stimuli, like for example, defect in immunity or stress or trauma, which is everybody knows. So in the nature, there is almost around more than 100 herpes virus in the nature. 8 of them commonly causing diseases in the humans. But in the eyes, most likely 6 of them, which is marked in red, it can cause eye diseases or eye problem. We can classify herpes viruses that causing disease in the humans into 3 groups: alpha viruses, beta viruses, and gamma viruses. Alpha viruses, which they have latency in neural tissue, and the strong evidence now lately in the literature that also these viruses can be isolated from the corneal stroma, like herpes simplex virus 1 and 2 and varicella zoster virus. Beta viruses with a latency in myeloid cells like cytomegalovirus. And the gamma viruses, like Epstein-Barr virus, human herpetic virus 6 and 7, and human herpetic virus 8, which was isolated from Kaposi sarcoma. So let's say a very simple and fast introduction about the anterior uveitis. It's the most common intraocular inflammation, which accounts for more than 90% of uveitis seen by community ophthalmologists, by general ophthalmologists in PHC in the primary care. But this figure is reduced to 30 to 60% diagnosed as a tertiary referral centers. But we found that more than 50% of patients develops complications due to the uveitis related to their disease, and 35% can suffer a severe visual impairment or severe visual loss. But if it's not treated and managed properly, it can lead to legal blindness, which accounts for almost 5 to 10% of all causes of legal blindness in the United States and Europe, and this figure raised to 25% in developing countries, secondary to uveitis. So we are talking about very serious disease, and disease can lead finally into loss of vision. And the problem that it can be treatable, and it can be treated very easily if it's diagnosed on time and correctly diagnosed. Let's few words about the herpetic anterior uveitis, the major cause of infectious anterior uveitis in both developing and developed countries. There is a lot of papers in literatures about the epidemiology and accountability of herpetic anterior uveitis, but I try to summarize them. From 0.2 to 15% of etiological diagnosis of uveitis is due to the herpetic herpes viruses, and in developed country from 0.8 to 14%. In Saudi Arabia, we have one paper published by our university hospital by Dr. Huda Dhahri and Prof. Abu Assar that is the third most common cause of anterior uveitis after idiopathic and fox uveitis, almost reached 13.3%. Two other populations also published by Dr. Islam and Dr. Tabara, it's also the same figure, around 12 or 15% of uveitis patients by etiology, it is caused by herpetic group of viruses. Other important observation here that the incidence at the onset of uveitis is only 4 to 9%. And this is increased to high as 44% after a long period of follow-ups in some series and some studies. What does it mean? It means that there is a high missed or ignored diagnostic rates. So in one of the papers by Mizuroshi published in 1995, they found that 70% of 41 patients, it was misdiagnosed as a herpetic anterior uveitis and diagnosed as idiopathic. And they found that the average time interval between the onset of the ocular disease of uveitis and the correct diagnosis is almost 3.4 years. We have one patient in uveitis clinic of Prof. Abu Assar and King Abdulaziz University Hospital. He was diagnosed as glaucoma for more than 20 years. And he was using anti-glaucoma medication until seen by our glaucoma fellow or glaucoma, and he saw small KPs in Fearley and referred to us. And it was a cytomegalovirus anterior uveitis. And this patient, once he received valganciclovir, after a few weeks, we stopped using anti-glaucoma. More than 20 years, this patient was diagnosed as a glaucoma without a proper diagnosis. So, why we are talking about the herpetic anterior uveitis? First of all, we have to stress on a few points. First of all, is the epidemic increase in some strains of herpetic group of viruses, like, for example, herpetic simplex virus 2 and cytomegalovirus. There is increasing seroconversion of herpetic simplex virus 2. For example, in 2006 in the United States, more than 25% of the patients at 30 years of age, they have a seropositive for herpes simplex virus 2. We know that before in our literature that herpes simplex virus above the waist infection, below the waist infection, but this is not true nowadays. So there is increase in the trend to developing ocular diseases by herpes simplex virus 2. And also cytomegalovirus, there is a new forms of viruses that become increasing, causing anterior uveitis, especially in Asia. The second thing, improvement in molecular diagnostic testing the intraocular fluid using PCR or detecting the herpetic antibody. All these become very advanced lately, which shows that many cases we diagnosed before as idiopathic anterior uveitis, it becomes herpetic, which shows antibody or shows DNA of herpes viruses in intraocular fluids. And also, as we talked before, the important cause of infectious anterior uveitis in both developing and developed countries. High missed or ignored diagnostic rates. A delayed diagnosis can be happens for years, and it's a blindness disease. It can lead to glaucomatous optic atrophy if it's not detected and managed early before the development of persistent complication. And easy to manage. Once you diagnose it, A, B, C, you can manage it easily and treat medically without using any surgical intervention. So for all these points, why we have to study and we have to understand and correctly diagnose herpetic anterior uveitis. Just a small figure, I want to show you just the types. Usually herpetic uveitis can be classified into either herpetic keratouveitis. I put it specifically, or I put it in a specific group because it's easily to diagnose and manage. Herpetic, there is, for example, dendritic ulcer, there is a stromal keratitis associated with a kipes, associated with anterior chamber inflammation, easy to diagnose, so straightforward diagnosis, so it's most likely herpetic. But we have a problem in cases of just purely herpetic anterior uveitis. There is no keratitis at all. And these, we classify them into two groups, either conventional, directly hit by a virus, or as as a presumed syndromes, hidden by another disease or other syndromes, which is called a presumed herpetic uveitis. Like, for example, Posner-Skolzman, Fox uveitis, corneal endotheliitis, sectoral iris atrophy with iritis, immune recovery uveitis. All these, it's a syndromes, but inside of them, if we'll do PCR, they will find, in majority of patients, will find some sort of herpetic viruses. So it's herpetic anterior uveitis can be presented directly or can be presented as a presumed syndromes. Herpes simplex 1 and 2, it can be a first manifestation of herpetic eye disease in around 4% of patients, 12% as a manifestation of recurrence. It can be as anterior uveitis, keratouveitis, sclerokeratouveitis in almost 85% of patients. Remaining is as a retinitis. It can be presented as acute, chronic, or recurrent disease. But also herpes simplex, it can present as a presumed anterior uveitis. We can isolate, in using PCR, herpes simplex viruses in Posner-Skolzman, in Fox, and also in endotheliitis. Also in idiopathic hypopigmentation of the iris. They found many literature papers, they isolate the herpes simplex virus. Varicella zoster, also it can cause a chronic anterior uveitis in addition to shingles and other diseases. Cytomegalovirus, it's a new type of viruses, just less than a decade. There's a lot of papers trained about this type of viruses. It's commonly cause anterior uveitis in immunocompetent patients. It's many forms. It can be acute relapsing anterior uveitis or chronic hypertensive anterior uveitis, or in form of presumed anterior uveitis, as the arrow is going to shows in form of Posner-Skolzman, Fox, endotheliitis. This very commonly, we found in PCR, we found cytomegalovirus. Epstein-Barr virus also can be shows chronic anterior uveitis in addition to the posterior uveitis. Herpes simplex virus 6 and 7, some papers about panuveitis. 8 can also cause panuveitis isolated from Kaposi sarcoma, just in simple and fast. Now, let's have a roadmap how to diagnose a patient, correctly diagnose a patient with herpetic anterior uveitis. The diagnosis of herpetic anterior uveitis is based mainly on clinical features. It's a clinical diagnosis, but it can be assisted. Okay, if it's available according to the center, or depends on the center, by PCR or detection of the herpetic antibody specific to that virus. But the clinical features, we noticed that the clinical feature is variable. It's not the same. It's variable. The same virus can cause different pictures, and also the same virus can cause different pictures in different population. This depends on many factors: the immune state of the host, which is the humans, and the virus load, seroprevalence of different strains, and host genetic susceptibility. What does it mean? That if the patient came, or if the patient has lowered or decreased immune status, this is most likely, in cases of cytomegalovirus, to cause cytomegalovirus retinitis. While in an immunocompetent patient, it can cause anterior uveitis. Usually, herpetic anterior uveitis due to herpes zoster, it comes in elderly, and usually it can be associated with disturbance in the immunity. Virus load, when there is a high attack of the viruses, the picture is different from due to the immune reaction. Usually the immune reaction, it can cause low-grade inflammation with less, for example, iris atrophy, and with, or iris or pupil abnormality, and the IOP is not that much high. In opposite to when there is a high virus load, it can be associated with the high IOP reaching 50, okay? And in addition that, the patient with a severe iris atrophy secondary to the ischemic necrosis, occlusive vasculitis. So the virus load itself, when it's a high virus load or low virus load, it will change the picture. Seroprevalence, as we talked before, herpes simplex virus 2 in states and Western countries is increasing. Cytomegalovirus in our countries and also in Asian. Host genetic susceptibility, still there is a lot of debate. Why, for example, cytomegalovirus can be presented as a Posner-Skolzman or can present as a Fox or as endotheliitis. It depends on many factors. One of them is the genetic, the behavior of the host. We don't know a lot, still we don't know a lot about these issues. So herpes simplex, varicella zoster, and cytomegalovirus, they have certain clinical features in common, but they differ in significant aspects. So we have to talk with them together, and then each one will be described separately. Now, I will try to summarize diagnostic approach or roadmap. So to easily, if the patient came to me, how I can reach the diagnosis, the correct diagnosis. First of all, any unilateral hypertensive anterior uveitis, unilateral hypertensive, iris atrophy, plus minus corneal scar. These four features is herpetic anterior uveitis until proven otherwise. Okay? So unilateral hypertensive iris atrophy plus minus corneal scars is herpetic until proven otherwise. So now, I am worried. This patient is herpetic. What is the next step? I want to rule out other causes of hypertensive anterior uveitis. We know anterior uveitis is usually associated with a ciliary shutdown and low IOP. So when a patient presented to me with a high IOP in acute stage, at the presentation, I have only very few differential diagnoses. The most common of them is herpetic. Others, like for example, toxo, like syphilis, like sarcoidosis, like leprosy. So we have to put this, and I have to rule them out. This is the first, by either clinically and by some investigation if I want to do it. So, and the other issue that usually the high IOP in herpetic is different from the other diseases. In what? First of all, usually in herpetic anterior uveitis, you have a mild or moderate anterior inflammation. Just 1+, 2+. While, for example, if toxo or, for example, sarcoidosis, it comes to you with a severe anterior chamber inflammation. And this is associated with a high IOP due to a clogging or of the inter-inflammatory cells or pigments. The second issue, that the hypertension or intraocular hypertension due to the herpetic, it will not respond to the inter-inflammatory. And it will not respond to the improvement of the anterior chamber reactions, in opposite to sarcoidosis or toxo. But only it will respond if you will give the patient systemic antiviral. So this is other differentiation between the hypertensive or high IOP due to herpes or due to the other diagnosis, in addition to the other clinical and diagnostic features. Now, the third step, I have to group herpetic uveitis into two groups. Herpes simplex and varicella zoster into one group, and cytomegalovirus in the another group. Why? Because the management is different. Prognosis is different. Okay, so I am trying and easily to differentiate between both of these groups. Sometimes it's difficult to differentiate between herpes simplex virus and varicella zoster virus. Very difficult. There's a few points, but it's not conclusive. But easy to differentiate. Is this cytomegalo virus or this is another herpetic viruses? Usually these three: herpes simplex, varicella zoster, and cytomegalovirus. These are the main three which causing anterior uveitis. طيب. There is a table. It's a very interesting table. Really, I found it in a paper published in Clinical Ophthalmology in 2015 by Owe Player and Faik Chi, and also Dr. Shi, shows most of the differentiation points. But let us first talk about how to differentiate between cytomegalovirus and herpes simplex varicella zoster. First of all, the age. Cytomegalovirus can happen at any age. Either it's acute, younger, or chronic at the older age. The second issue, the males is the most common, and predominantly Asian. This is according to the paper, but we can see it in both. In our clinic, Prof Clinic in Uveitis and King Abdulaziz, we see males and females. But the very important point to differentiate is starting from outside to inside, the cornea. The corneal sensation in cytomegalovirus is normal, while in herpes simplex, herpes zoster is reduced. Number two, the cornea itself is normal. You cannot see scars indicating previous stromal keratitis, which is common in herpes simplex and herpes varicella zoster. But in cytomegalovirus, the only thing what we can see, nodular endothelial lesions, which is more in chronic, and the immune rings. But the cornea itself is clear. The other differentiation points is what about the pupil shape? Herpes simplex, varicella zoster, they associated with abnormality in the pupil, which is early, it can be this abnormality in the pupil due to the iris stromal edema, severe inflammation, while lately to the iris atrophy, while in cytomegalovirus, normal pupil. The other issue, what we can notice also, there is no posterior synechia in non-surgical eye in cytomegalovirus, while in herpes simplex, herpes zoster, the posterior synechia can develop at different percentages. Iris atrophy. Usually in herpes simplex and varicella zoster, they are sectoral or spiral, while diffuse and patchy in cytomegalovirus. So these few points, it can give me a clue that is this herpetic is cytomegalovirus or herpes simplex varicella zoster viruses. After that, I will go to the next step. If it is herpes simplex varicella zoster, so I will see if I can differentiate between them. It's very difficult. Okay, and the points between them, it's non-conclusive. For example, herpes simplex is usually recurrent disease, usually younger age. Varicella zoster is a chronic, elderly. The other differentiation points is, for example, if there is a crops of vesicles, periocular in herpes simplex. In varicella zoster, I can see dermatome blisters. And the other point also, they can differentiate is there's claiming that in varicella zoster virus there is a high incidence of vitreal debris and vitritis. Anterior uveitis, we didn't see that much. So now, when I reach to, if I could differentiate between them, it's okay. If I couldn't, it's okay. Also because the management is almost the same, although the doses of the systemic antiviral is different. Now, if the patient presents to me as a presumed syndrome, is it this presumed, is this Fox or is this Posner-Skolzman, is herpetic or not? This we will talk about it later. So this is another step. And the final step, if I want to confirm the diagnosis, I should do PCR or herpetic specific antibody titer. So this is just, I am summarizing the differentiating points between three of them. Cytomegalovirus can be acute in form of Posner-Skolzman or chronic in form of Fox uveitis, commonly in males, Asian, no rash, no keratitis, can present at the nodular endothelial lesions, normal corneal sensation, patchy or diffuse iris atrophy, no posterior synechia, and normal pupil. Herpes simplex virus, usually is unilateral, but bilateral from 8 to 18%, different papers, mainly in atopic patients, younger age, recurrent course, plus minus keratitis, plus minus periocular vesicular rash, and reported to cause Posner-Skolzman, Fox, acute iris depigmentation, and pigmented glaucoma. Varicella zoster virus, older, chronic course, dermatomic vesicular rash, vitritis is common. Now also the same, I will show you here the picture, just few slides. Now, this patient is presented, this is our uveitis patient in a Prof. Bulasar clinic. This patient is presented to us with a stromal keratitis
associated with the large mutton fat kipes. I didn't talk about the kipes now. Why? Because in herpetic, all of them, they can be presented either as a granulomatous or non-granulomatous. It can be presented under large mutton fat kipes or stellate kipes. But the peculiar issue in herpetic uveitis that most of the kipes, they are not respecting the Eyelid's triangle. They are not coming in the inferior triangle of the cornea. Usually it's coming distributed all over, which is not common in the other causes of hypertensive uveitis like in sarcoidosis or like in toxo. Okay, so what we have here, large mutton fat kipi distributed all over, associated by stromal keratitis. So this is direct, straightforward. This is herpetic uveitis. We can see here a patient acutely presented with a mild inflammation, presented with an irregular pupil. This is before, without dilatation due to the iris trauma, edema. And this is the mutton fat kipi distributed all over. And this is after treatment, what we'll notice, sacral iris atrophy. So this is most likely, it is a herpetic, this is a herpetic anterior uveitis, not cytomegalovirus, either herpes simplex or varicella zoster. Now other patients, also with a herpetic anterior uveitis, we can see here there is a posterior synechia. Usually, as we said, in non-surgical eye cytomegalovirus, it is not presenting with a posterior synechia, even with the active inflammation. And here we can see there's a sectoral iris atrophy, which is a very pathognomonic to herpetic anterior uveitis. Now, cytomegalovirus. Usually, cytomegalovirus can be presented either in two forms, either acute relapsing, recurrent, hypertensive anterior uveitis, or chronic hypertensive anterior uveitis. How we can differentiate between them? Usually they are claiming that in cases of a chronic hypertensive or chronic cytomegalovirus, they are more elder age. The males is almost reaching 80%. The kipes is a stellate kipes, in opposite to the acute, which is a large granulomatous kipes. And in addition that, these patients, chronic, they are associated with a mild raise in the IOP, in opposite to the acute, as we said, it can be presented as Posner-Skolzman. IOP can be reached up to 50. In a chronic cytomegalovirus, it's around 30, maximum 35. But the prognosis later on, risk of cataract and glaucomatous optic neuropathy is more with the chronic cytomegalovirus than acute relapsing cytomegalovirus. Okay? Dr. Shi, in 2008, she published a paper about the differentiating the features which can be differentiated between the Posner-Skolzman and the Fox and a virus itself, which they found that 23% of hypertensive anterior uveitis is due to the cytomegalovirus. 75% had Posner-Skolzman at the presentation, and 21% has a Fox uveitis, based on PCR. So as we said before, mainly male Asian, no rash, no keratitis. What about the nodular endothelial lesions? They found that when the high virus, cytomegalovirus usually associated with the high virus load. And this high virus load, it's mainly affecting two things. Affects the endothelial cells causing endotheliitis and the trabecular cells causing trabeculitis. So it leads to inflammation of the trabecular meshwork leading to high IOP and affecting the endothelial cells leading to the endotheliitis. One of the important lesions is nodular endothelial lesions in form of round. We can see it here, it's very clear in form of round, gray, white, round lesions associated with the translucent halo. This is very pathognomonic for cytomegalovirus anterior uveitis, especially chronic. It can reach up to 60%. Honestly saying, we didn't see that much in our prof clinical uveitis. We didn't see this endothelial lesions too much, but they found that this endothelial lesions indicating that the acquirement of the endothelial cells by a high cytomegalovirus. So this is published by Kozomi in 2008. And the positive predictive value for the correct diagnosis of cytomegalovirus anterior uveitis can reach up to 91. Other issue, according to the Mayanaga, published in 2010 by British Journal of Ophthalmology, they found other non-invasive technique that reduced endothelial cell count may strengthen the suspicion of cytomegalovirus in the absence of keratitis. You know, we can specular microscopy, we can do it in the clinic. Every clinic we have it. So we can reduce, we found that there's a strong correlation between cytomegalovirus infection and between the corneal endothelial cell count. More inflammation, more reducing count. And this will continue to deterioration in the number of the endothelial cells until we are giving or hitting by a high systemic antiviral like valganciclovir. So it can halt deterioration of number of the endothelial cells. As we said before, normal corneal sensation, patchy or diffuse iris atrophy. Why there is stromal iris atrophy? Why it's diffuse? Because of the high virus loads, because of the live viruses in the anterior chamber. And this will cause severe damage, or what is called as occlusive vasculitis to the iris blood vessels, and leading ended with stromal iris atrophy, which is diffuse. And therefore, when there is when there is a diffuse iris atrophy, therefore there is no place for the posterior synechiae to develop. There is no iris trauma. So therefore, no posterior synechiae will develop in cytomegalovirus. Normal pupil, delayed arm retinal. This is another feature here by Dr. Wong and Chi, published in Clinical Experience Ophthalmology in 2014. They found that non-retinitis, posterior segment changes can be happen sometimes in cytomegalovirus in form of delay in arm retina time in fluorescein angiography, some epiretinal membranes, macular edema, disc swelling, and periphlebitis, which is not specific, by the way. The other differentiating features of cytomegalovirus, it is resistant to any anti-inflammatory medication and systemic acyclovir. The only response with the ganciclovir or valganciclovir, and this is in literature is a positive predictive value of reaching around 95%. Now let's talk about, we finish about the normal cytomegalovirus. Now let's talk about how cytomegalovirus can be differentiated between presumed syndrome. Is it cytomegalovirus related or not? First of all, let's talk about the Fox uveitis. In 2008, they isolated herpes simplex virus, cytomegalovirus, and rubella DNA has been detected in eyes with a Fox uveitis. And also, Dr. She noticed that she put some points that they can differentiate, is this a cytomegalovirus-related Fox uveitis or just typical Fox uveitis. She found that 41.7% of all presumed cases of Fox uveitis are cytomegalovirus positive. And they are usually associated with the elder age. Yani typical Fox medium age, but cytomegalovirus anterior uveitis in forms of Fox, it's elderly, which is 57 years or older, and the median age is about 65 years. 80% of the patient are male, and 70% can be bilateral. Usually in Fox uveitis, up to 7 to 17% of the patient is bilateral, and it presents as bilateral anterior uveitis. It's not sequential. It cannot present for today, and after that it will develop unilateral Fox, then bilateral Fox. No, it presents as a bilateral Fox. And cytomegalovirus, another differentiation point, is that most likely to have a nodular endothelial lesions. But from literature, I can summarize a few points that can help me in the diagnosis. Is this a Fox uveitis, just typical, or cytomegalovirus Fox uveitis? The most important differentiation feature is about the KPs. Usually we know in Fox, as a manifestation, usually the KPs is stellate, as an 3F, keratouveitis, sclerokeratouveitis, in almost slightly 5% of patients. In addition that, in Fox uveitis, it can be presented as acute, chronic, or recurrent disease with the medication. But in stellate KPs, in cytomegalovirus Fox, usually after treatment, the KPs are disappearing or becoming pigmented. Other point about the iris atrophy. Usually in Fox uveitis, typical Fox, the iris atrophy starting at the papillary border, therefore no posterior synechiae. In cytomegalovirus, the iris atrophy, it becomes very diffuse all over the iris. The other point is the IOP. Elevated IOP in cases of typical Fox, it will not respond to steroids or only respond to antiglaucoma. While in cases of cytomegalovirus Fox, if we are giving antiviral medication, we don't need antiglaucoma later on. So this is not a fox. Other issue, the other differentiation point that usually typical fox associated with the iris nodules in 1/3 of the patients, and in almost 78% of fox, they associated with a vitreal debris and vitritis due to the cyclitis component of the disease. Therefore, in literature, now they are classifying fox as an intermediate uveitis. So I hope these differentiation point can help me to rule out, is this typical fox or this is fox due to the cytomegalovirus. Now, Posner-Skolzman disease. Now there is increasing trend in the literature that Posner-Skolzman is a just acute relapsing cytomegalovirus and TR uveitis. And Dr. Shi, according to her paper, she found that 52% of all presumed cases is cytomegalovirus positive. And there is no clinical features to differentiate between cytomegalovirus positive or negative eyes. Because now we are thinking and that this is one disease, is not different diseases. طبعا the median age of patient is in cytomegalovirus positive virus is positive Posner-Skolzman 37 years, more than 60%, 5% are male. Now the other form is corneal endotheliitis. We noticed that endotheliitis and TR uveitis are different patterns of cytomegalovirus and TR uveitis. So that cytomegalovirus can be happens as an endotheliitis. طبعا why endotheliitis happens, why this form happens, they found that if there is a high virus load, high active live viruses in the anterior chamber, it can lead to severe endotheliitis because the direct hit of the endothelial cells by the active cytomegalovirus. And Dr. Shi again, she suggests that in corneal endotheliitis due to cytomegalovirus, it's more common in men, in Chinese, can be unilateral or bilateral. It can cause blurred vision, as we know, due to the corneal edema and descendant folds. But the pigments are tended to be pigmented, the KPs are tended to be pigmented, and often arranged in a linear or cone-shaped pattern. And more specific is the oil eyes lesions. What is the oil eye lesion? It's intranuclear intranuclear inclusion bodies with the macrophages accumulating in the endothelial cells secondary to the active cytomegalovirus infection. And this is very easy. It can be diagnosed using a specular microscopy. So on confocal microscopy, we can diagnose, and very pathognomonic for cytomegalovirus due to the cornea, cytomegalovirus inflammation. So this is the other point, and in addition to reduced corneal endothelial cell count. So the pathophysiology, in short, I will specify that the cytomegalovirus uveitis, it can classify, we can group them into three parts, either pure anterior uveitis associated with the trabeculitis and the endotheliitis. Anterior uveitis can be due to the active viral replication, ischemic vasculitis with a leakage of inflammatory cells, and in addition to the immune reaction of the eye in the eye. Trabeculitis and the endotheliitis is caused by the direct live viruses in the anterior chamber. The same thing about the varicella zoster virus, but only Kizuka in 2002 noted that the presence of delayed hypersensitivity to varicella zoster virus antigen, it can reduce the anterior uveitis caused by varicella zoster virus. In cytomegalovirus, also the same. It has high seroprevalence and long life latency of this virus. Also, in addition to hematopoietic and endothelial cells, is responsible for a frequent reactivation in immunocompetent patients. Reactivation is the same as any other herpetic virus secondary to stress, infection, trauma, or corticosteroid immunosuppression. So this is the problem, that the last point here, that interaction between the viral load and the immune state of the eye is responsible for the different presentation of the cytomegalovirus in the eye, whether it is just a purely cytomegalovirus, whether it's acute or chronic, Posner-Skolzman, or fox uveitis. Investigation very fast. We'll talk about it. Direct evidence using a viral culture. We can take specimen from a blood, lymph nodes, aqueous, retina, vitreous. But indirect evidence, which is, it's commonly based on two things: PCR, detection the viral DNA aqueous analysis, and intraocular viral antibody production using a Goldman-Whitmer coefficient, which is more than 3. Now, there's 2 points I want to mention here, that usually in acute disease, PCR is more efficient than intraocular viral antibody production, Goldman-Whitmer. In a chronic, usually due to the inflammation and due to the immune reaction, so Goldman-Whitmer coefficient is more efficient than PCR. And in immunocompetent patient, PCR sensitivity of PCR is equal to the Goldman-Whitmer coefficient. But in immunocompromised patient, PCR is very golden standard. You have to do it. So, but to give a high sensitive and a high specific diagnosis, we need to do both of them. A new non-invasive technique is just to do a specular microscopy, especially in cytomegalovirus and uveitis, and look for if you found endothelial cell count is reduced, OLI lesions, and also the type of KPs. طبعا PCR, I will not talk about the types of PCR, but there's a very increasing in advancement in PCR now in form of real-time PCR, multiplex, and nested. About the specular microscopy, we can see here endothelial cell counts usually reduced. The only one to halt reduction or damage of the endothelial cells is using of systemic antiviral. OLI signs, also we can see it as we said before, it's a suggestive of cytomegalovirus anti-uveitis. Type of KPs, they found there's many types of KPs, but we can find here this either dendritic, globular, or diffuse, smooth or cuticular, but they found that when you're doing specular microscopy, dendritic and diffuse form, it's most likely suggestive of infective pathology, but this is not conclusive. Just I found it in a few papers. Now, after we reach the diagnosis, how we'll manage these patients? As we said, presumed anterior herpetic uveitis, rule out after differential diagnosis, differentiate if possible between 3 forms, diagnostic confirmation, then I have to evaluate the prognosis and the counsel with the patients based on the onset diagnosis factor. What means onset diagnosis factor? It means that if the patient to present to me acutely and I diagnose him correctly, then the prognosis is very good. The patient will not suffer from deterioration of complete or permanent visual defect, and he will have a high chance that we'll stop using medication at some time. But if the patient has a late onset, incorrect diagnosis for longer duration, it means that this patient, he may develop glaucoma complication, he may need glaucoma surgery, and maybe I cannot stop, I cannot withdraw him, and he will use, for example, antiviral for longer duration. The main management, 3 things: systemic antiviral, topical anti-inflammatory, and anti-glaucoma medication. But it depends that in cases of herpes simplex virus and varicella zoster virus, I can use a systemic Zovirax, 400 milligram, for example, 5 times for 6 weeks, then I will taper. But there is a high risk of relapses. So I have to taper very slowly using anti-systemic, systemic antiviral, I have to use it. In addition to topical anti-inflammatory, I will not give topical anti-inflammatory without a cover of systemic antiviral, in addition to anti-glaucoma, because the glaucoma is a part of the disease, so I have to give anti-glaucoma medication, topical. So usually topical corticosteroid Q2 to 4 hours initially, then QID, then slow tapering for weeks to months. Oral acyclovir 5 times a day for 100 for 4 to 6 weeks. Maintenance therapy, I will keep it according to the Herpetic IDC studies, 400 milligram BID. It can help me to preventing relapse. Alternately, we can use valacyclovir. It has more improved bioavailability. And systemic antiviral and low-dose steroid drops we can use for years. But we have patients in our clinic after few months, we can stop anti-glaucoma, we can stop anti-inflammatory, but just we are keeping him on very, very maintaining dose of acyclovir. The same thing about the varicella zoster virus, but the only thing we start to hit with the high dose, like 800 milligram 5 times a day, then especially if we start the medication within 10 days, or for 10 days within 72 hours, it will give a better prognosis. Longer duration of treatment is needed. Maintenance dose of acyclovir 400 milligram TDS, it can be beneficial, and in addition to anti-inflammatory and anti-glaucoma. In cytomegalovirus, we know that they will not respond to acyclovir. They have to hit more stronger, like valganciclovir therapy for 6 weeks, and then after that taper it accordingly. and we can reach a stage that we can avoid or stop using anti-inflammatory and anti-glaucoma. This is many modalities has been tried to treating cytomegalovirus, but the one with the blue is the most we are using and very successfully giving good results. Some people, they are doing intravitreal ganciclovir have been tried, topical ganciclovir gel, ganciclovir implant also was tried, but we found that 75% of all treated patients, or all these modalities, they are relapse. They respond, but the disease is relapsed is in about 65% of patients. Therefore, the only one we found that in oral valganciclovir, only 35% of patients, 34% of the patients relapsed after discontinuation of the medication by using oral valganciclovir. So this is the most efficient way of management, but the problem that we have to be aware about the toxic and the systemic side effects, like for example, liver function, renal function, and also the cost. It's a very expensive drug. There is one paper I showed that by Dr. Anton is published in 2015, the cornea. Luckily that one of the patients, I don't know luckily or unfortunately, the patient is pharmacist professor, and he tried, instead of using oral valganciclovir, he tried to manufacture and tried to do a topical valganciclovir from the tablets. And after a few months, still he was using this, the inflammation subsided, but the IOP is still high. He was using anti-glaucoma. So he found that better to do, instead of manufacturing or doing from valganciclovir tablets, doing drops, doing gel. And he did the gel, and he claimed, according to this paper, that after a few months, he stopped using anti-inflammatory like steroids, and he stopped using anti-glaucoma. He even published in the journal the way of formulation of 1% topical valganciclovir ointment. As finally we can say that we have to investigate this more. At the end, herpetic anterior uveitis is the most common infectious cause of anterior uveitis. High misdiagnostic rate. Diagnosis is based mainly on clinical features. We should be aware about the various presentation of herpetic anterior uveitis. Early correct diagnosis and correct management dramatically improve the visual outcome without visual complication. And further research needed to study the pathophysiology of different presentation of the disease and the new modalities of a cheaper treatment. I hope that at the end I can reach our goal, not making the upper slide here. I make you in this slide. Thank you very much.
Thank you very much, Dr. Manar. I would like to congratulate Dr. Manar for an excellent presentation. Now we can open the floor for discussion. Dr. Abdullah.
Thank you, Dr. Manar, for a nice presentation, well informative. Just a couple of comments. First, I agree with most of what you said. The only thing that I disagree that it is easy to treat. One of the slides that you were saying that it is diagnosed and then easy to treat. In general, herpetic is one of the most challenges for us in the anterior segment. It's one of the most challenges to treat. Yes, they respond to the treatment first, but they have higher risk of recurrence. They have risk of complications. So the treatment usually is not as good as the diagnosis. The second comment is the use of PCR. I think it is helpful, but a few tips if you want to take the PCR, to take it from the anterior chamber, avoid touching the blood vessels, and contamination of the needle may give you a false positive result. And I remember 2 cases that confirmed to be positive for a CMV. My third question for you, if we treat those patients, will be transferred to negative, because there is a couple of patients that I share management with the Prof. Ahmed, and they clinically diagnosed as CMV endotheliitis. And one of them I did for her cataract, and the other one I did for her DSEC. And when I sent the specimen for PCR, it was negative, though it was clinically proven to be CMV. So the question, is it after the treatment they will go back to negative PCR?
But these patients, Abdullah, received the ganciclovir.
Yes, they were treated with ganciclovir.
Thank you for your comment. First of all, maybe what I mean that easy to diagnose. Yeah, maybe I said managed, but it's easy to diagnose. Management, I know, the herpetic is very hard also, even in keratitis, but it's easy to diagnose based on the clinical dendritic ulcers or stromal keratitis. About the other point, that usually when you are giving valganciclovir, we are hitting very strongly the live viruses. It will reduce in quantity in a large amount, but there is a few remaining, which is you can cause an immune reaction, and this is what's called the balance. Sometimes it's presenting at an acute phase like this, and the chronic phase different presentation. Depends on the balance between, but will not eradicate the virus. The virus will not be eradicated. It will still there, especially it's a latent virus. It can, with any changes in immunity, any change in the condition, the virus again would flare up. So therefore, we have to keep a low dose of systemic antiviral for longer duration. Although in literature, as I said, 65% we can use after 14 months, there is one paper, 65% of patients, they are stopping using valganciclovir. Maybe Prof has any addition?
In fact, most of the patients, if we diagnose them clinically with cytomegalovirus anterior uveitis, and with time, now we know that the clinical presentation is very highly suggestive. If a patient presents, as the Dr. Manor mentioned, high intraocular pressure, patient is using topical steroids and anti-glaucoma drops for years, it can be up to 20 years. Then the presence of a corneal edema is highly suggestive. He showed one patient, if you can show this patient again, because the CMV virus tends to cause endotheliitis, and corneal edema is very, like this is a patient. Can we have light down, please? So this is a lady, she is about 65-year-old. At presentation, she had pressure that was about 35 millimeter of mercury, very chronic use of topical steroids and anti-glaucoma medication. At presentation has corneal edema. Why corneal edema? Because cytomegalovirus tends to cause endotheliitis. And in addition, she had diffusely distributed matum fat keratic precipitates. Based on this clinical presentation, we started the patient on valganciclovir. Valganciclovir is a very expensive drug, and thanks to our administration at King Abdulaziz University Hospital that they made it available for us. So after a few days of valganciclovir, the intraocular pressure was controlled. We were able to stop anti-glaucoma medication. So we kept the dose at maximum dose, 900 milligram, 2 times a day for 4 weeks. Then we tapered to 450 2 times a day for another 4 weeks. And then 1 tablet per day, and then 1 tablet every other day, and then 1 tablet every week. And we stopped everything, and you can see cornea became clear. The patient underwent cataract surgery by Dr. Abdullah Al-Fawaz, and there is no recurrence. In fact, in our experience, the rate of recurrence, we see it, but it is not as much if you give them the full course of valganciclovir. When the first person to describe CMV anterior uveitis in immunocompetent, because all of us know that cytomegalovirus retinitis is a disease of immunosuppressed individual. But in immunocompetent individuals, that was described by Dr. Nikos from Greece. And at that time, it was very surprising data. Cytomegalovirus causing anterior in immunocompetent, but gradually there were more and more reports about this. So it's a disease that we should be able to suspect and to treat correctly.
Comment, if you allow me. Also, if you have a patient who is having BKB, I have 1 or 2 patients, they had BKB and they have failed graft after 2 years. One thing to suspect, and it was reported also in the literature, is CMV endotheliitis, because it may recur and cause decompensated cornea. And there was a patient, they had failure of a graft based on recurrence CMV if they didn't treat it well.
Yeah. You have a question? Okay, go ahead.
Thank you. It was a very good presentation. Just one question about talking about the recurrence rate in CMV iritis. I think there are a couple of papers from Prof. Chi group that use of topical ganciclovir gel can reduce the risk of recurrences. Have you have any experience of that?
No, this is just a case reports, just for one case, as I mentioned. But
No, I think they've got a big case series, so I think maybe 36 patients or something like that. From same group from Singapore, and I think there's another one from Belgium actually as well.
yeah, now this paper, for example, United States, these are people they are claiming that they can preparing a valganciclovir from the tablets, doing gel, doing topicals, but we didn't have any experience with this.
They're talking about the ganciclovir gel, the normal.
Ganciclovir gel was tried. Yes, I said in my lecture, but the recurrence rate they found is very high. It's reaching up to 75%. So it's not optimal. I cannot just, this is a disease. If you don't hit it correctly from the beginning, it will lead to serious complication.
No,
So therefore, it is not. They are claiming, yes, I agree with you. They said that they try it, but the recurrence and relapse rate is very high, reaching up to 75. I saw it. Yes.
Okay. Well,
Yahya.
Thank you, Dr. Manar. It was very nice presentations. My question regarding the, if you plan to do surgery in those patients and the patients already off medications, did you resume the antiviral medications for those patients or not?
In fact, we have one patient that will be operated by Dr. Abdullah Al-Fawaz. I'm not sure. The patient is already on maintenance dose for 150 milligram per day, but to be cautious, we shall resume the full dose 1 week before surgery. But I don't think there's literature that discuss this issue. But it's better to give the patient the maximum dose before surgery and to taper it after surgery.
Are you going to taper the same way?
Yes.
Over like
yes,
over 3
yes.
months?
But in these patients, you don't need, as we do, for example, with VKH, you don't need to give large dose of systemic corticosteroids before and after surgery. Topical is enough.
Before the surgery, and then
Yes.
we see it and taper it over a month.
Yeah.
Like
yeah.
what we are doing in HSV.
Yeah. Yeah.
But again, we don't have clear guidelines in the
Yes.
literature
Yeah.
to do that. Topical ganciclovir, I use it in 2 patients. Both of them were suspicious. They were not confirmed by PCR. One of them both defect. Just did her recently. And we had some histopathological signs of suggesting of herpetic without knowing the nature. When I discussed it with Dr. Hind Qattan. So I gave her the topical, and now she's almost more than 10 days, and the cornea clear. We don't know is it because of that topical medication, but we will have a longer
Without
follow-up.
systemic treatment.
Without system, because we don't have the diagnosis. It was
but-
failed graft. Came to me.
But the patient is on heavy topical steroids.
Yes.
So if there is a suspicious of herpetic, I think it's better to cover the patient with systemic antiviral, at
Yeah.
least acyclovir.
The problem with her, she's a failed graft. She's one-eyed patient, failed BKB.
Yeah.
And the history she's saying to me, it get failed over the 4 years, which is unusual.
For
to have
herpetic.
failed graft in 4 years. And she gave history also of high IOP with anti-glaucoma medication. That made me suspicious. Even when we did the surgery for her, she was not having the usual course of DSEC that we usually have the clarity in 2-3 days. When we initiate the medication and rebubble her, she improved. But still, until now, I am not sure that is it a herpetic uveitis or just a failed graft.
Oh, yeah.
We're just doing regrafting for her. Time will allow us to see more
Inshallah.
and assess her AC reaction.
Last question. Dr. Asamar.
Thank you, Dr. Manar, for this overview lecture. Just want to comment about if you allow me, about the CMP. Yeah. Yeah, I just agree with what Dr. Manar and Professor Abu Asra mentioned about the importance of using the oral galvancyclovir in this CMV. In fact, 4 years ago, we invited one of the group who published that article in the American Journal of Ophthalmology. She was from Singapore.
Dr. Chi.
Yes,
Yeah.
when she arrived, and she gave us the an introduction about this kind of infection. It's almost like unknown or extremely rare in the North American, and since her lecture, we started to see like 2 or 3 cases a year in our
Yes.
division in anterior segment.
Same maybe anterior uveitis.
And yeah, exactly. So
Yeah.
it's not something uncommon, and it's not rare in Saudi Arabia. That's
Yeah.
number one. It's but it's uncommon, but it's not as common as the Chinese population. That's number one. The second thing is that at that time, many of our patients were diagnosed as what all of you mentioned as a herpetic, and they never responded to Vergan, because we introduced Vergan almost 5 years ago in Kekash, and we are not using Zovrex at all. So almost all those who were resistant to Vergan and who were misdiagnosed as a herpetic, two cases of these, they responded well only after oral. So as
You mean Valgan's ointment?
the gel, we do have the gel from
Gel.
Via, from
But-
Via
and
company.
they don't respond to the gel, but respond to the
To
tablet.
the oral, yes.
Yeah.
So that's the second message. This is our
Yeah.
brief just experience here in Kekash. Yeah.
In fact, the last patient that I saw with this diagnosis was a 35-year-old lady. She was treated in an important hospital for years with systemic corticosteroids and mycophenolate mofetil, in addition to topical steroids and anti-glaucoma drops. The diagnosis was very obvious that this is CMV anterior uveitis bilaterally, and after treating her, we stopped, of course, mycophenolate mofetil, corticosteroids, and we gave her valganciclovir, and we were able to quieten the eye, to stop Brit 40 drops, and also stop anti-glaucoma medication. So many of these patients, as Dr. Manar mentioned, are diagnosed very late, and that will create a lot of complications. The patient had bilateral posterior subcapsular cataract. She will undergo cataract surgery in our institute. And she had some disc changes, glaucomatous optic nerve head changes. So I think Dr. Manar, his choice for the topic of this lecture is very important, so that everyone in this room would know about the spectrum of herpetic anterior segment inflammation, so that we can avoid many of these complications. I said the last question, but okay.
Treated previously CMV, and he is quiet. What do you recommend? Only oral prophylactic treatment?
As we said earlier, Dr. Fawaz just mentioned it. We'll resume the full antiviral treatment like 1 week before surgery, and we taper gradual after surgery.
Even topical and oral. Only
Oral,
not
yes.
topical.
No, not but about the PCR, just one last comment. There is one slide, just I passed very fast for a time. In this slide, they mentioned that PCR is, there is a high false positive and high false negative for certain conditions. Therefore, PCR alone itself is not that accurate diagnosis, only if you're giving PCR with detection of the antibody, herpetic antibody. It depends on the coefficient. So both of them is highly sensitive and highly specific. But one of them, it give you some time. The most accurate, if you want to do a PCR, as you said, Dr. Fawad, avoid the blood vessels, but also do it during the acute attack of high IOP. It gives you the most predictable results.
Wait. So before we conclude, because Dr. Manar talked a lot about Whitmer's coefficient, and I am sure most of the residents in the room, they don't know about Whitmer's coefficient. Anyone in the room knows about Whitmer's coefficient to diagnose the viral infection? So it's very important to explain what is Whitmer's coefficient. So Whitmer's coefficient is based on taking aqueous humor sample and the blood sample from the patient. And you measure the specific immunoglobulin for this particular virus, and the total immunoglobulin. And the ratio, specific immunoglobulin, for example, varicella zoster or CMV virus, specific immunoglobulin in the aqueous, by total immunoglobulin, by specific immunoglobulin in the blood, by total immunoglobulin. If the coefficient is more than 3, it indicates infection by this virus, like cytomegalovirus. This, in the past, they were using the cutoff value more than 1. But it happens that if we use a cutoff value more than 1, there will be many false positive cases. So the coefficient should be more than 3. So this is the coefficient. So everyone, especially the resident, will know about it. Thank you very much. Can I have help, please? أنا خليتك تقعد يا محمد لأنه مهم. خلاص هو جاي. جولدمان ويتمرز كوفيشنت ها؟ Wait, eye and systemic. I think this should be this one. Yes. شكرا. Shall we start quiz? So this is the first patient. I prepared like 10 questions, so there will be a bonus for the residents. So the first patient is a 65-year-old male who presented with a sudden onset decreased vision with visual field defect in his right eye. So this is his fundus picture. And this is fluorescein. So please describe, give the diagnosis. Second case, 35-year-old woman. She presented with a bilateral disease. This is her right eye. Left eye. Look at the periphery. There is fibrovascular tissue. I'll make it easier for you. But look at the arteries. Then periphery. Fluorescein angiography. Look at the periphery. So please, and also have a look at the retinal arteries. So diagnosis and management. Three-year-old girl, she presented with exotropia in her right eye. So this is the main reason that the mother brought the girl to ophthalmology. So this is fundus picture, fluorescein angiography. So diagnosis. Fourteen-year-old female presented few cells in the anterior chamber, matum fat cratic precipitates. This is her optic nerve head. Periphery, look at the blood vessels. Fluorescein angiography, right eye, left eye, periphery, indocyanin green angiography. Left eye indocyanin green angiography. So what is the most likely diagnosis? When you put all the signs together, what would be the most likely diagnosis? A 35-year-old male, he had bilateral disease, but look at the anterior segment, cornea, iris, cornea, iris, fundus, optic nerve, posterior retina, ICG, indocyanin green angiography, the other eye, fluorescein, ICG. So what is, please describe the findings. This is very important. As I always say that in uveitis, you have to examine the patient carefully, then you write the positive findings, and then you put these findings together in order to reach a diagnosis. So what is, just describe the findings, the clinical findings, and the differential diagnosis. This is a young lady, anterior segment. Look at the findings in the anterior segment, just describe it. And this is her posterior segment manifestations. Fluorescein angiography. Here, what is the most likely diagnosis? I think all these cases we discussed before many times in the CTR, so that's why you have to give the right diagnosis. Faisal, no discussion. The clue here to make the diagnosis is the fundus. 28-year-old female presented with bilateral decreased vision, anterior segment examination was normal, vitreous was clear. This is her posterior segment. Fluorescein angiography, very clear fluorescein angiography, left eye, indocyanin green angiography, right eye, and left eye. What is your diagnosis? Thirty-year-old male presented to the emergency room, visual acuity with only count finger, 4 blood cells in the anterior chamber, as you can see, severe vitritis. Through the vitritis, you can see retinal lesions, left eye, both eyes, fluorescein angiography, right eye, left eye. Diagnosis and first line treatment. A 50-year-old lady presented with high intraocular pressure, you can see the anterior segment manifestations, and few weeks after receiving a specific treatment. Diagnosis. This is again to enforce the lecture given by Dr. Manar. This is another case. Diagnosis. Fundus was okay. Now, next case. African lady. She was about 36-year-old. She presented to the emergency room, high intraocular pressure in the affected eye. Anterior segment showed these findings. and pseudous segment examination showed these findings. So what is your diagnosis? Should we repeat it? So first case, a patient presented to the emergency room with reduced vision in his right eye. Diagnosis: a patient that had bilateral disease involving the pseudoretina, and you can, if you look carefully at the course of the arterioles, perhaps this can help you to make the diagnosis even here. So this is the periphery, this is fluorescein angiography, diagnosis: 3-year-old girl, only right eye, fluorescein angiography, diagnosis: 14-year-old female. This is her left eye. Look at the disc and look at the periphery. Fluorescein angiography, indocyanine green angiography, diagnosis: a male patient, anterior segment, cornea, iris, posterior segment, indocyanine green angiography, left eye, indocyanine green angiography. A young lady, anterior segment, inferior fundus, and fluorescein angiography. Another patient, a young lady, completely normal anterior segment examination, fluorescein, indocyanine green angiography. A young male, 4+ cells in the anterior chamber, and this is his posterior segment, right eye, left eye. Diagnosis and first line treatment: 55-year-old lady, high intraocular pressure at presentation, treated for long time with topical steroids and anti-glaucoma medication with no response. The lower picture is after starting specific therapy. Young African lady, anterior segment, posterior segment, diagnosis. So can we collect the answers, please? We still have 3 case presentations, so please let us move. Shall we start discussing the cases? Huh? So I want to discuss the first case. By the way, all these cases were discussed previously either in CTRs or perhaps in the exams. So it should be easy. Okay, Abdurrahman, what is the diagnosis of this case? Combined with central artery occlusion. Is that a good answer? Branch artery occlusion. So this is, if you, why Abdurrahman you said central retinal artery occlusion? لأن the ischemic whitening is involving only one sector of the macula. So this is supratemporal branch retinal vein occlusion, artery occlusion combined with central retinal vein occlusion. Why central retinal vein occlusion? Because we have venous congestion, tertius and hemorrhages. And these are not features of pure branch retinal vein occlusion, branch retinal artery occlusion. So the clue here to make a diagnosis is the presence of venous congestion tortuosity with intraretinal hemorrhages, which suggest central retinal vein occlusion. Next case. If you look at the patient had some sort of vasculitis involving arteries or veins. Arteries, okay. And the patient, if you look at the course of the arteries, it is not very clear, but you can appreciate here some sort of irregularities. There are some sort of irregularities. And in the periphery, you see here neovascularization, which means the peripheral retinal ischemia. Fluorescein angiography, it will show you peripheral retinal ischemia. So we have a patient with bilateral peripheral retinal ischemia. The differential diagnosis of peripheral retinal ischemia will be like occlusive vasculitis, sickle cell disease, and the others. Fever. And the patient, in addition, she had, what is this leakage? From where? Neovascularization. So when you put this find together, the most likely diagnosis will be IRVAN. IRVAN is idiopathic retinal vasculitis, aneurysms, and neurotenitis. So the patient, because the patient had peripheral ischemia with neovascularization, what you should do? You have to add a scatter laser to the retinal periphery, and that's what we did to the patient, followed by complete regression of the new vessels. Next case, what is Iman? What's your diagnosis? Gaucher disease, excellent. It can happen. It is rare, but it can happen. So the patient had a large amount of subretinal hard exudates. If you look in the periphery, you can see the aneurysmal dilations. And the fluorescein, it will show the aneurysmal dilation and peripheral retinal ischemia. How would you treat this patient with exudative retinal detachment? We give, first, this patient, I drained the subretinal fluid because the subretinal fluid, you can see here how high, so the laser will never take. I applied laser and I gave intravitreal triamcinolone also. This is also has been shown to be effective. And this was followed by flattening of the retina and absorption of the subretinal hard exudates. But we are left with a scar. This eye is amblyoptic, but at least you kept the eye. If you don't treat this disease, this eye will progress into neovascular glaucoma and not only functional loss of the eye, but also cosmesis, functional loss of cosmesis, and the eye might need to be inoculated. But we, with our management, we were able to preserve the eye. Now, this is a case. What is your diagnosis here? First of all, what are the findings, clinical findings? How about the optic disc? Swollen. How about the periphery? Focal vascular sheathing. And how about the granulomas? So if you put these things together, what is the most likely diagnosis? Sarcoidosis is the most important differential diagnosis here. As we discussed many times, sarcoidosis is a disease which, in which the optic nerve head swelling is common, either due to inflammation or due to infiltration by sarcoid tissue. Now, this is a patient who had, what is the, how about the cornea here? Matum fat. How about the iris? Suggesting granulomatous inflammation. Now, how about the Basal segment? Multifocal choroiditis. So what can cause this combination? Tuberculosis is the most important differential diagnosis. So this is a typical phenotype, clinical phenotype of tuberculosis. And the ICG will show you that the lesions will cause persistent hypofluorescence. Now, this is a patient. What is wrong with the anterior segment? Matum fat KP is granulomatous. Now, how about the retina? Suggesting of what? Excellent. So this combination, this picture is highly suggestive of multiple sclerosis. And the patient had multiple sclerosis. In addition, look at the focal leakage and inflamed optic nerve. But those who are answering are third and fourth year residents. We need to listen to second year residents. Now, this case, oxidative retinal detachment and pinpoint leak and pooling of dye under the neosensory retina, other eye, ICG, many hypofluorescent spots indicating granulous inflammation. So this is initial onset acute Vogt-Koenig-Harada disease. How would you manage it, Iman? Who is else here? Second year resident? يلا يا فيصل. Excellent. So this is typical for Behcet, ban uveitis, and fluorescein angiography, diffuse leakage involving the capillaries, as you can see here. And what is the first line of treatment in this particular case? Infliximab is the first line of treatment. Now, this is a patient. All of us now, after the lecture of Dr. Manar, should know this is cytomegalovirus anterior uveitis with endotheliitis, exactly the same case as he added to his lecture. Corneal edema because of endotheliitis, matum fat KPs, diffuse, and after Valgan cyclovir treatment, complete control